Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling melanoma. If you haven't listened to our last episode on basal cell carcinoma, now would be a great time to rewind and give that a listen, get those basics of skin cancer down, and today we will move on to melanoma. So as always, let's kick it off with our practice question. A nurse is conducting a skin assessment on a client during a routine physical exam. Which of the following findings should the nurse recognize as potential indicators of malignant melanoma? Select all that apply. We have A, a mole with one half noticeably darker and larger than the other. B, a flat tan-colored lesion present since childhood that hasn't changed in size. C, a skin lesion with varying shades of brown and black pigmentation. D, a newly developed mole that measures 7 millimeters across. And E, a mole that has recently begun to bleed and developed a crusted surface. So think it through, tuck your answer potentially away, and let's talk about melanoma. We will come back to this correct answer at the end. Melanoma is the most dangerous type of skin cancer, so you really need to be able to recognize it quickly. And to understand melanoma, we have to start with the melanocytes. These are the cells that produce our pigment, our melanin, and they are located in the basal layer of the epidermis. So by making melanin, their job is to give skin its color, and that melanin also protects us from UV radiation. It's kind of like these cells are making our skin's built-in sunscreen because it's going to absorb and then scatter those harmful UV rays, and that prevents DNA damage that can turn into skin cancer. So here's the catch. When UV radiation, maybe from the sun, maybe from tanning beds, repeatedly damages DNA inside those melanocytes, we get mutations. Over time, the melanocytes stop following normal growth controls. So instead of dividing and dying off like they should, they start multiplying out of control. They invade deeper and deeper layers of the skin, blood vessels, they can get into the lymph system, and that's how we get a melanoma. That's how something simple transforms into a malignant cancer. So if you remember back to Tuesday's episode on basal cell carcinoma, sounds pretty similar. We have cells dividing out of control. They're in the basal layer of that epidermis, but it doesn't spread. And that's not so much what happens with melanoma. It does not play by that same slow growing rule that the basal cell carcinoma does. Melanocytes are very mobile by nature. So when they turn cancerous, they have a really high potential to metastasize. Metastasize means spread. These cancerous melanocytes can spread to the brain, the lungs, the liver, the bones, and then boom, we've got cancer all throughout the body. That makes melanoma really, really dangerous. We go from small skin lesion to a life-threatening systemic cancer kind of fast. So very important, we're looking for it early. How do we do that? There are 5 basic things we look for. It is the early detection rule of melanoma, and that is the ABCDE rule. You just have to know your ABCs. Let's go through them. A is for asymmetry. Basically, if you draw a line through the middle of a mole, the two halves should match. In melanoma, they don't. One side might be darker, larger, shaped differently, etc. That's the A, asymmetry. B is for border. A normal mole is going to have a smooth, even border. Melanomas are irregular. Their border is blurred, ragged, kind of like the edges are like melting into the surrounding skin. They are not going to be smooth and even. So B, border. Next, C is for color. Normal moles are going to be one shade of brown, okay? They can range from light to dark, but the whole mole is the same color, whereas melanomas have a mix of colors. They can be a little black, brown, red, white. They can even have some blue in them because the cancer is growing unevenly within the lesion. So if you see multiple colors, C for color, you're worried about melanoma. D is for diameter. Melanomas are usually larger than 6 millimeters across or in diameter, and that is about the size of a pencil eraser. So, not to say that a melanoma can't be smaller than that, it definitely can. If you see it's asymmetrical and it has irregular borders and it's multiple colors, but it's only 4 millimeters, you still need to be suspicious. They just grow really fast. So, usually by the time people are coming in, they're getting bigger. So, the rule is if you see something bigger than a pencil eraser, bigger than 6 millimeters across, go ahead and raise the red flag. We need to get it checked out. That is D for diameter. And then we have one more rule, E, that stands for evolving. Any mole that is changing in some way, the size, the shape, the color, the elevation, or the symptoms associated with it. It's like, hey, this started bleeding, or now it's itchy, it's crusting over. Any symptom that is new or changed, that means that it is evolving. That is our E. That tells us we're worried about melanoma. So, a good analogy when we're thinking, is this a mole? Is this melanoma? Think of it as a tenant. A mole is a good, well behaved tenant. They stay put, they pay their rent, they don't cause trouble, they're not throwing a bunch of different colors of paint up on the wall. Melanoma is a really bad roommate, all right? They expand, they change the space around them, and they won't stop until they've taken over the whole apartment. And we don't want that to happen. So, as a nurse, it's our job to recognize these signs really early, raise that red flag, and get them looked at. The key takeaway here is that while melanoma begins in those melanocytes, those cells that produce pigment in the basal layer of the epidermis, they spread rapidly and they're very mobile. So, melanoma metastasizes. Follow the ABCDE rule to recognize early and get intervention. Which brings us to talking through our case study for today. So, just like in our last episode, you are a nurse in the dermatology clinic today, and you have a 52-year-old come in. We're going to call her Miss Dalton. She is, again, 52. She is a first grade teacher. She is coming in for a mole on her back that, in her words, quote here, has been acting weird. So she says, first, my husband noticed it. He was like, this looks darker and bigger than before. That made her alarm bells go off. So she made the appointment and came in. So let's start with your physical exam. You help her into a gown. Look at her back. We've got an irregular asymmetrical mole on her upper left shoulder. It's about the size of a pencil eraser. It has uneven borders that fade into the surrounding skin. The color is not uniform. It has black, brown, a little bluish gray. And when you ask about symptoms, she says it started itching a few weeks ago, and when she scratched it, it bled a little bit. So think back to our ABCDE rule. A for asymmetry, check. We've got an asymmetrical mole. B for irregular border, check. Uneven borders, they're fading into their surrounding skin. We don't have those nice clear edges. C for varied color, check. Again, we saw it was black, brown, it had a little bit of bluish gray. A normal mole should be all one color. Now, D for diameter, we said it was about the size of a pencil eraser. That's 6 millimeters. That is our threshold. So D for diameter, check. And lastly, E, evolving, that is a definite check. She's got new symptoms. The itching, she scratched it, it bled. Those changing symptoms, along with her husband said it looked darker, the color changed, it looked bigger, the size changed. All those changes, evolving, E, check. This mole really is very suspicious for a melanoma. I want to be clear that not all of them will check every single box. Even when just one of these boxes are checked, we still want to look into it. But if you have A, B, C, D, E all acting funny, you know we need to get the provider looking at this because something's going on. So what they're going to do, the dermatologist comes in at that point and they're going to do a dermatoscopic exam. So they have this dermatoscope that is basically a very fancy, very precise magnifying glass. It gives us a nice big lit up view where we can see the lesion's pigment pattern, vascular structure, and just get a super in-depth view. So the dermatologist does this, and then they decide what action needs to be taken further. In this case, for Miss Dalton, they decide to do a punch biopsy. What's that? Basically, we're going to punch through that mole, and we're just going to take a little sample of it. We can send that off to the lab so that they can then look at those melanocytes and say, are they cancerous? Is this melanoma? And very importantly, has it spread? Because remember, by nature, the cells we're talking about, those melanocytes that produce pigment, the melanin, they're very mobile, which makes melanoma likely to metastasize. And that's what we're worried about. And in this case, the pathology report does come back as malignant melanoma. It is early stage, so it hasn't spread to the lymph nodes or distant tissues, which is really the best news you can hope for in this possible case. So, what are we going to do to treat melanoma? We have got to get that out of there. There is no place for melanoma to stay. So, we are going to do something. By we, I mean the nurse is going to assist and coordinate, and the dermatologist is going to perform a wide local excision. This is first line treatment for a melanoma. Basically, the surgeon is going to remove not just the visible mole, but also a margin of normal appearing skin around it. So that's why we call it a wide excision. The reason for that is because those melanoma cells are very mobile, they can send out microscopic, kind of, we'll call them roots, beyond just what we see on the surface. So we need to get a wide excision of clean tissue around it to make sure we get all that yucky melanoma out of there. If we leave any, it can still spread. All right. So then, as the nurse, lots of education to do. Let's start with pre-op education. We need to talk about what to expect both before and after surgery, keeping the site clean, monitoring for signs of infection, avoiding direct sun exposure, especially during healing. But that's going to be a big part of melanoma prevention. We also want to talk about lymph nodes. We are worried about melanoma spreading into the lymph tissue. So it is possible that they will do a lymph node biopsy to just check if any melanoma cells have migrated over to the nearby lymphatic tissue. All right, post-op, what are we going to talk about? Wound care, very important. We do not want infection, so good old wound care. We also want prevention education. We know we got to avoid the sun while healing, but those UV rays are what caused the melanoma. So preventing further melanoma, we got to wear sunscreen, at least SPF 30, and reapply every 2 hours. Wear long sleeves, hats, UV blocking sunglasses, block those UV rays. In addition, they need to do monthly skin checks because having one melanoma increases your risk of developing another melanoma. So every month, check for those moles, and you need to teach them the ABCDE rule so they know what they're looking for. And with that being said, that is a great way to bring us back to our practice question because hopefully now you know that rule and you can get to the right answer and understand why. So we've got a client. We are assessing their skin during a routine physical exam, just like we did for Miss Dalton. Which of the following findings would you recognize as a potential indicator of malignant melanoma? Select all that apply. We have a mole with one half noticeably darker and larger than the other. Is that an indicator of melanoma? Yes, that is asymmetry. That's your first rule. All right, B, we have a flat tan colored lesion present since childhood that has not changed in size. Would that be an indicator of melanoma? No, B is incorrect. A flat tan colored lesion present since childhood, this is probably describing something called a cafe au lait spot. It's a normal birthmark. It hasn't changed in size. That's not going to make us think melanoma. B is incorrect. C, we have a skin lesion with varying shades of brown and black pigmentation. Would that make you think melanoma? I think you guys know it would. C for color. Those different colors, that makes us think melanoma. A normal mole, all one color. Then we have D, a newly developed mole that measures 7 millimeters. Does that make you think melanoma? It absolutely does. That's D for diameter. Anything bigger than 6 millimeters or the size of a pencil eraser. And lastly, we have E, a mole that has recently begun to bleed. Would that make you think melanoma? Yes, that is E for evolving. Any change in shape, size, elevation, or symptoms all make you think melanoma. So A, C, D, and E are all correct there. And your key takeaway here is really to know those A, B, C, D, E's. I know we've been through them a bunch, but hey, melanoma is aggressive. If we catch it early by knowing our ABCDEs, we can catch it, we can get it all out of there, and we can prevent it from spreading and taking someone's life. So you play a vital role in recognizing and educating clients. Early detection here really does save lives. So you've got to know those ABCDEs for melanoma. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.